Hi, I'm Jack Cush. I'm here in the Room Now booth with a panel of experts on spondyloarthritis. I want them to introduce themselves. I'm Jack Cush in Dallas.
Christopher Ritchlin, University of Rochester.
Sofia Ramiro from the Netherlands.
Lianne, Gensler, UCSF in San Francisco.
Jesse Walsh, Salt Lake City.
All right, so what I'd like you to do is, why don't we just introduce some of the interesting new trials and new data that's been presented in AS and spondyloarthritis. Dr. Walsh, why don't you start with one of your favorites?
One of the most interesting trials for me at this meeting is the Maximize trial, and in which secukinumab was evaluated in patients with axial psoriatic arthritis. That was diagnosed according to the clinician's opinion of whether they had axial disease, and it appeared to have efficacy in this population of axial psoriatic disease patients, maybe similar to what we're seeing with AS and non-radiographic trials.
So is axial psoriatic arthritis going to be a new indication? Is that an unmet need? And there's a little bit more buzz about that.
Yeah, I think the axial psoriatic arthritis phenotypes are a little bit different than what we typically think of with ankylosing spondylitis and non-radiographic disease. And we still don't really have any great consensus or definition of what it is, but we do know that in a lot of patients it looks quite different. Maybe there's less sacroiliitis and more spinal, even when they've got spinal involvement, not contiguous lesions, the spinal involvement, bony production looks different. So I expect, and they may or may not be a little bit less symptomatic. Yep. So I expect this population may have some differences in terms of how they respond, and it's very appropriate to look at them separately.
Another trial.
I think we need a stronger definition of who these patients are.
I was going to say exactly the same, because they may or not be different, but I don't know what we are talking about when we are talking about patients with psoriatic arthritis that have axial involvement. Why isn't it axial spondyloarthritis then with psoriatic, with psoriasis, with skin involvement? And those trials, how have been they defined? Because you're saying maybe they have more inflammation in the spine, but I don't think that has been measured. They have been defined, the population has been defined based on the presence of back pain. So that is a bit ambiguous and I think non-specific definition, and I think if we want to study, we need a better definition, and I doubt there is a difference between actual SPA and PSA with actual involvement.
Yeah, I agree with that statement. And if you look at the paper from Deepak Jaden, where he serially looked at patients with AXPA and also patients with psoriatic arthritis who had axial involvement, they were remarkably similar in terms of their level of pain, in terms of other findings. The only thing that was really different was the extent of radiographic bilaterality, obviously, in the ankylosing spondylitis group. But I think one of the interesting aspects of this trial is it was a peripheral psoriatic arthritis group, and they had to have a BASDI of greater than 4 and a pain score over 4. We don't know about the imaging yet,
yes,
but apparently they've done it, right? So this is going to be really exciting to sort of layer that over these results when we see it. And we're all waiting with bated breath, so I agree.
Chris, do you think that this is representative of all of the psoriatic axial patients? My suspicion is the ones who we are recognizing are the ones who look most like AS and the more traditionally defined non-radiographic disease, and that when we get into the phenotypes that may be less recognized, for example, the patients with spinal involvement without sacroiliitis, I think there's where we may find bigger differences.
Yeah, we might. And again, the imaging will help us sort that out, I hope.
Yeah, but I think it's better to first work on a definition and then look at the trials, because at this moment, did any of us expect different results from this trial than the ones we got? I think not, because if patients have actual involvement, if we know that the drug works in actual SPA, why would it not work in patients with PSA in which it works with actual involvement?
I think it's an unmet need. I think there needs to be more research,
exactly.
We need to see
the
data.
definition first.
Yeah.
Lianne, what do you want to talk about?
Yeah, I'll switch paths just a little bit. The first study in non-radiographic axial spondyloarthritis using an IL-17A inhibitor, ixekizumab, presented at this meeting showing efficacy in this population. It was a 52-week double-blind randomized controlled trial, so that's an incredibly long period potentially for placebo, with the option to cross over to treatment, but clearly showing efficacy in this group. of patients with non-radiographic disease. I think that's been a question. Do these patients really need to be treated with biologics, or is their natural history more mild? And showing that the drug works and that these patients don't remain in a placebo group for the duration.
And we're talking about non-radiographic axial SPA with objective signs of inflammation.
Thank you for the clarification, right? So absolutely. So these patients going into that trial were required to have some amount of objective inflammation, either on MRI or by CRP or both. And so that is typically the way we treat these patients, though I think daily clinical practice. We expect to see, if there's no damage, that they have some amount of inflammation.
So we have a drug now that's approved for non-radiographic axial SpA and certolizumab, right?
Yes.
And now we're seeing more trials in this. Are each of you using the term and treating patients as such as non-radiographic? Forget the fact we don't have an ICD-10 code for it. But do you actually do this in your clinic?
Yes.
Absolutely not.
We see a difference overseas, but in Europe we do that.
Chris, you?
We do it, yes.
But actually, to be more correct, what I do is use the term axial SPA.
I do the same.
Yeah,
Yes.
so
Yes.
because it doesn't really matter whether it matters for some indications for the indication of some drugs, but for the patient, it doesn't really matter whether it's non-radiographic or radiographic. But I call it axial SPA.
I want to let the panel know, last year we had another panel of austere, great rheumatologists here in the spondyloarthritis space, and 4 out of 5 were like, no, it's really not a useful term for us in clinic, and maybe what you said is more right. If they have axial disease, they have axial disease, and you treat it as such.
And I think as experts, we see them as one patient population warranting the same treatment. I think in the US, unlike Europe, is we now only have one drug approved. So if I label someone as non-radiographic, and the payer sees that there isn't a drug approved for that, then I will get denied. And so for me, the more appropriate term is really how I diagnose someone, not how I classify them.
That's true.
And we also know how little reliable is the scoring or the reading of the X-rays in the presence of radiographic sacroiliitis. So in the end, what matters is whether patients have axial SPA or not, and the classification is more for study purposes than for daily clinical practice.
All right, next trial. What do you got?
Another trial, another molecule that we have seen is bimekizumab. So it's an IL-17 inhibitor, but it inhibits IL-17A and IL-17F with a rationale that the double inhibition will lead to more suppression of inflammation. It's a phase 2b trial. It had previously shown positive results at the primary endpoint of 12 weeks, and now we have seen extension until 48 weeks. And what we see is that patients continue showing an increase in their response more or less up to week 24. There we see a plateau, and then the response continues stable until week 48. So it's a positive trial with promising results. The phase 3 trial phase 3 program will start. So we will have to wait until we have more data to see if this drug makes it to daily clinical practice. But it's promising so far.
So Chris, you did the trial with bimekizumab in psoriatic arthritis. What did you think of the AS data?
I think the AS data is very impressive, extremely so, and as was the psoriatic arthritis data. So the idea that blocking IL-17F is going to add a little zip above IL-17A looks to have some validity. Obviously, phase 2 trials, you have to be careful of getting too excited about the data, and so the phase 3 are going to be very informative. And I think they're both underway. I know PSA is.
And radiographic and axial SPA also, they're also underway.
And you know, despite adding a blockade of IL-17F, the safety looks pretty similar to what we see with IL-17A blocking agents, so that's really encouraging.
Chris, you have a trial that you're excited about?
Yeah, Jack, I do. I think that we're all looking forward to additional mechanisms and therapies for treating ankylosing spondylitis, axial SpA, and of course the new entry into these therapies are the JAK-STAT molecule, the agents that block the JAK-STAT pathway. We've seen data so far from tofacitinib and filgotinib, but at this trial there's data on another JAK1 inhibitor, which is upadacitinib, affectionately called UPA. And in this phase 2 trial, they showed a very sizable effect size using the ASAS-40 as the outcome measure. And I think this is another piece of evidence that an oral medication that focuses on the JAK-STAT pathway has some potential to be a therapy for this disease. Obviously, I know that TOFA is in phase 3. I think filgotinib is as well, and we'll have to look for phase 3 data. But I'm very hopeful that we'll have additional treatment options for our patients with axial SpA ankylosing spondylitis.
And I think I so appreciate this as well, because otherwise all we have are injectable biologics, and this is a young population of patients. And so having an oral option for them will be really important.
And it's also very good to have an option for patients that have extra-articular manifestations and that have failed to a TNF inhibitor. We know that with IL-17 inhibitors, we have more difficulties in treating those patients, so this may open up possibilities to treat those patients.
I agree.
I'll ask an obscure, bizarre question to end. Is there a trial that any of you are looking forward to or waiting on that you think is the next big thing or is important to you coming up, but not yet ready?
These phase 3 trials we were mentioning.
Yeah. That's what we would
I think what's coming, not this meeting, but I'm looking forward to head-to-head trials.
Yeah.
We're all
And
looking
strategy
forward to
trials
that.
as well.
And
if we start having more options, I think it would be good to also have strategy
Yes.
trials.
At the end of the day, it's easy to show compared to nothing, but we don't use nothing anymore, and so really what's superior becomes important.
We could question ourselves to what extent it's relevant in 2020 to show superiority to nothing.
Right.
I'm also interested in looking at more real-world data and patients with less severe disease, and seeing how some of particularly the JAKs may perform.
It's very true,
In a broader population of spondyloarthritis patients.
The other element I'm interested in is in the JAK stat category, how much of the improvement is related to pain and how much is related to suppression of inflammation and osteitis. And I think that's a fascinating question, and we're going to get some answers when we have additional imaging in the future.
I want to thank the panelists for their great insights and for coming here and sharing their perspectives from the meeting. That's it from Room Now on spondyloarthritis.